Let us discuss a case of medicine today. So let's say a patient has presented with ascites in your OPD and you have to approach this case. Or this question can also come in the form of what is ascites, what are the causes of ascites, and how do you approach a case of ascites. For any question in medicine, surgery, obs, gynae, or pedia, or be it any clinical subject, you try to follow the sequence. And the mnemonic for the sequence is deep CS at CP. There is a deep CS at CP. D stands for definition, E for epidemiology, E for etiology, P for pathogenesis, C for classification or staging of the disease, S is the symptoms or the signs, A is the approach, which stands for the diagnosis, T is the treatment, the next C is for complications, and lastly P is for prognosis. If you remember this sequence, you can attempt any question that is given to you. Let's take up ascites today. So as I said, we'll start with the definition of ascites. What do you mean by ascites? Ascites is the accumulation of excess free fluid in the peritoneal cavity. There is already some fluid in the peritoneal cavity. When there is excess of this free fluid, that is called as ascites. Next is the etiology or the causes. Now you can divide the causes in any question into common and some uncommon causes. And as ascites is the accumulation of fluid, you know it can be transitive or exudative. Now what is the difference between transitive and exudative? Transitive is mainly due to the increase in the hydrostatic pressure in the blood vessel, or it can be decrease of the oncotic pressure, plasma oncotic pressure of the blood vessels or the capillaries. Whereas exudative are usually the increase of the permeability of the capillaries, which can happen due to infections or malignancies. This is a concept which will be required in pathology as well. The difference between transitive and exudative. Okay, leaving that aside, let's come to the causes of ascites. Common, uncommon causes. Transitive. Remember 3 causes or 3 DDs for each of the causes. Transitive can be due to congestive cardiac failure, due to protein energy malnutrition, and due to nephrotic syndrome. Sorry, it's my mistake. It can be due to congestive cardiac failure, protein energy malnutrition, and cirrhosis of liver. Now exudative, as I said you, it can be due to malignancy and infections. So it is malignancy, it is peritonitis, that is infection, and this is nephrotic syndrome. So nephrotic syndrome will be in the exudative causes. And there are some uncauses also, which includes vasculitis, abdominal tuberculosis, and Budd-Chiari syndrome. These are some uncommon causes of ascites. Okay, now causes done. Pathogenesis. So this is basically our pathogenesis. The transitive and the exudative thing is a pathogenesis. When there is increase in the hydrostatic pressure of the capillaries, when there is a decrease of the plasma oncotic pressure, and when there is increased permeability of the membranes, all this leads to the accumulation of the fluid in the peritoneal cavity, and that is what leading to ascites, and that is what causing ascites. So basically in pathogenesis, you can elaborate this point. Now, there is as such no clinical staging or classification of ascites, so I am leaving this point here. Let's go to clinical features, which includes symptoms and sign. The patient will present to you with abdominal distension, as I said in the question, abdominal distension and abdominal heaviness. But if it's a severe accumulation, then there can be cardiopulmonary embarrassment as well. Why? Because if there is too much fluid in the peritoneal cavity, that will push the diaphragm upwards, that will cause respiratory distress, that will cause pulmonary problems. So it is cardiopulmonary embarrassment when there is a lot of fluid in the peritoneal cavity. There are some signs as well. If a patient of ascites has come to you, you can see that he is having edema, right? There are some particular abdominal features which you can see, like bulged out flanks, very important term, eversion of the umbilicus, fluid thrill is present, shifting dullness is present, and divarication of recti. There is so much fluid in the peritoneal cavity that the recti is separated. So these are the 5 points which you should remember as signs of the abdomen in ascites case. Bulged out flanks, eversion of umbilicus, fluid thrill, shifting dullness, and divarication of recti. Now, come to the diagnosis or the approach. Approach, that is diagnosis. Any case you have to diagnose by history taking. So history is the elaboration of the symptoms that you have written. Then it comes to the general survey, like you do for any case. Then is the local examination. Then is the particular system examination, and there's some other system examinations as well. This is a case of ascites, is usually a case of GI. Here it is a case of GI, as I'm proceeding it with. There can be investigations also, which you will further do. Now, in history, just keep the causes in mind and then proceed forward. If it is ascites due to congestive heart failure, you will get symptoms of cardiac system, that is chest pain, palpitations, orthopnea, PND, paroxysm and nocturnal dyspnea. If it is a case of cirrhosis, you will get abdominal pain, abdominal fullness, distension, Features of jaundice may also be present, hematemesis, melena, nausea, vomiting, so all the features involving the GI system. If it is protein energy malnutrition, there will be a poor dietary history, a chronic history of weight loss maybe, or reduced appetite. If it is malignancy, very common, weight loss, anorexia, nephrotic syndrome, the patient usually presents with edema, which starts from the periorbital region, then it goes to the legs, and then it comes back to the abdomen. So periorbital edema, which is usually seen in the morning hours. And then peritonitis, itis, it is inflammation, so there will be fever, there will be pain, there will be nausea, vomiting. So just remember the causes in mind and go ahead with your history. Now one more thing is cirrhosis of liver. You should also take the history of alcohol, HBV and tuberculosis infection, because these can also cause cirrhosis, right? Now come to general survey. First of all, patient has come to you, you look at the overall appearance of the patient. You look at the face of the patient, look at the build of the patient, the nutrition status, the hydration status. So first is faces. If the patient is having ascites due to abdominal tuberculosis and malignancy, he or she will have a cactic appearance of the face. Then come to the important points. Icterus will be present in cirrhosis of liver. It will be present in malignancy if it involves liver, hepatic cell carcinoma. Clubbing will be present in congestive cardiac failure and metastasis from any other part. Edema in CCF, in nephrotic syndrome, in cirrhosis. JVP distension. JVP is characteristic of cardiac system, so CCF, congestive cardiac failure. Now, whenever you do the head-to-toe examination, the overall appearance, you get to see some features of the cirrhosis of liver. Like as this is cirrhosis of liver case, I am changing or I am dealing with that now. You get to see 5 important things, please do remember. You get to see palmar erythema, you get to see spider angina of spider nevi, loss of body hair, gynecomastia, and loss of testicular sensation or testicular atrophy. You also see Virchow's nodes, which is because of the malignancy, which can come from various parts like genitalia, breast, and your left supraclavicular node will be palpable, that is Virchow's node. So these are some of the general features, general survey points that you have to focus on. Edema, icterus, clubbing, cyanosis, overall head-to-toe appearance, and faces. Now, as I said you have to do a particular system, the concerned system examination. Here I am taking ascites due to cirrhosis of liver, so we do the abdominal examination. You have inspection, you have palpation, you have percussion, and you have auscultation. Under inspection, already I have discussed earlier, and the signs that your flanks will be full, your umbilicus will be everted, your abdomen will be distended, there will be spider nevi, there will be divergation of recti, and you get to see venous prominences because of portal hypertension. If you do palpation, you get to hear fluid thrill, shifting dullness will be positive. Whenever you do palpation, please remember to elaborate the liver and the spleen that you have found. In case of cirrhosis of liver, remember that liver is soft and tender, and it is shrunken in size. I'm so sorry. In case of cirrhosis of liver, your liver will be shrunken and hard, not soft and tender, but hard. Spleen will obviously be enlarged in cirrhosis of liver. Please note to measure the abdominal girth and the abdominal tenderness. Abdominal girth will be increased obviously in ascites because fluid is accumulated, and abdominal tenderness will be present in peritonitis or any other inflammatory condition. Hepatic bruit can also be felt under auscultation, which suggests a turbulence flow. Now, we move to the investigations part. So our history taking is done, our physical examination is done, our concerned system examination is done. Now we come to the investigations part. Very important thing in ascites is you have to do a diagnostic peritoneal tap, which shows you what is the color, what is the consistency of that fluid which is coming out. Obviously, if it is transparent fluid, you can make out it is cirrhosis of liver or it is congestive cardiac failure. If it is cloudy, that means there is some infection in it. It can be due to peritonitis, it can be due to malignancy. If it is bloody, that means there has been some trauma or malignancy. So it can be cloudy, it can be bloody, it can be clear. Now you do the cell count. Very important concept. Whenever bacterial infection is there, your neutrophil will rise. Okay, and whenever tuberculosis is there, your lymphocyte will rise. Remember this concept always. Any other bacteria will cause neutrophil to rise, but tuberculosis, because it involves lymph nodes, it causes lymphocytes to rise. Then you will do the protein content and SAC. Very, very important concept. If the SAC is more than 1.5, 1.1, or if it is less than 1.1. In one line, if SAC is more than 1.1, you do the protein count. If it is less than 2.5, it is portal hypertension due to cirrhosis. If it is more than 2.5, it is congestive cardiac failure. Very, very correct. And if it is less than 1.1, it can be due to infection or malignancy. Now you can also do culture and staining to find out what is the causative organism of infection, and you do the cytology for malignancy. And needless to say, there's some routine investigations which you have to do in all the cases, like the CBC, the urea create, the blood sugar level, the ECG, the LFTs, the serum amylase, lipase. You do electrolyte count, you do coagulation studies, you do chest x-rays, you do ECG. So these are very common investigations which are done for almost every case, and everything has an important association with it. There are some specific investigations which you have to do in case of ascites. For example, if ascites is due to cirrhosis, as I told you, it can be due to infections of HBV and HCV, so you do the serological tests. You can also do the liver biopsy, which is associated with it. If it is hepatic cellular carcinoma, it is alpha fetoprotein test that you have to do. Please remember this. And if it is TB peritonitis, you have to do interferon gamma test. Now, imaging should also be done, which usually involves the chest X-ray, USG abdomen, CCT, and if needed, Doppler study. So, chest X-ray will rule out cardiomegaly and pleural effusion. USG will tell you the amount of fluid that is present. It can also tell you about the liver and the spleen. The CT study will tell you if there is fluid in the pouch of Douglas, which may not be found in USG, and a Doppler study will tell you the portal vein thrombosis. So each test has an important role there. Now, there can be the staging of the disease. It can be grade 1, 2, and 3. Grade 1, as per USG or as per investigations, is the cytic fluid can be made out or detected by the USG. Grade 2 is when there is more fluid, advanced disease. So you can just see it by bulging of the flanks and shifting dullness. And grade 3 is when the ascites is visibly seen. You don't even need to do any examination, you can just see the ascites yourself. Lastly, we come to the treatment. Oh, yes, there's complications as well, but let's do treatment first. Any treatment, you go by general treatment and you go by specific treatment. General treatment for any disease will obviously be you ask the patient to take rest, take proper amount of fluids. There should be input-output chart that you should maintain regularly, and you should check your vital signs. This is common for every other disease. What is special about the ascitic treatment? There can be non-pharmacological advice, there can be a medical advice, there can be a surgical advice, and there can be definite management. Preventive or non-pharmacological advice is your salt reduction less than 2 gram per day. Fluid restriction, that is 800 to 1000 ml per day. And you have to check if there is any significant loss of body weight. Medical management is spironolactone and furosemide. The dosing is important here. Spironolactone 25 mg per kg per day, every 4 times a day, that is 100 mg per kg per day, and you can increase the dose to 400 mg per kg per day. But if it's tablet furosemide, you give it when spironolactone is not working, that is 40 mg per day, and you can increase it to 160 mg per day. So it's 100 to 400 spironolactone, it is 40 to 160 furosemide. If there is cardiopulmonary embarrassment, then you can remove the cytic fluid by paracentesis because the fluid has become too much. If there are signs of variceal rupture, you can give propanolol, 40 mg tablet, half tablet TDS, that is thrice a day. In surgery, you have tips, and in definite management, you have liver transplantation because the liver is going towards failure. Lastly, what are the complications that if you don't treat ascites, what can be the complications associated with it? Very, very important. Spontaneous bacterial peritonitis, which also comes with a short note. Then you have hepatorenal syndrome. Along with your liver, your kidney is also failing. So hepatorenal syndrome. You have portal vein thrombosis. You have hepatopulmonary syndrome. That is along with liver, your lungs are also failing. So hepatopulmonary syndrome. And lastly, you have pleural effusion. So 5 complications: hepatorenal, hepatopulmonary, umbilical hernia, pleural effusion, and spontaneous bacterial peritonitis. This brings us to the end of the video. We have discussed the entire ascites, starting from the definition of what ascites is to what are the complications which an ascitic patient can present to you with.